Why? I mean, if we can help reduce the load, we are in a pandemic. Why not ask people or try? They're not mandating vaccines. They're trying to coerce or encourage people to have vaccines. And, why not do that if it's going to reduce our deaths?
Well, I think the vaccine question, it's complicated, and to oversimplify it is dangerous. And what is right today is not necessarily right tomorrow, and was not necessarily right yesterday. But I think for the efficacy of the vaccine that we are seeing, and for the efficacy that was shown from the phase 3.
What do you mean by efficacy? You mean reducing infection or reducing
the overall overall efficacy? So if we kind of split it into different parts, contrary to the kind of popular narrative at the moment, many vaccines are effective at creating so-called sterilizing immunity, which is actually stopping people get infected, or at least stopping them getting infected to the point where they are ever infectious. Many, measles and smallpox and polio, you basically don't get infected, or if you get infected, it's so minor you never become infectious. You never contract any form of the disease, asymptomatic or otherwise. And most, not particularly the flu vaccine, but most long-term vaccines do achieve sterilizing immunity or close, where you don't get infected or infectious. And that may go against the popular narrative, but it just is. That just is. That's what most of the long-term vaccines do. Now, flu vaccines and some other vaccines do not achieve full sterilizing immunity, but they can reduce the severity of infection and the likelihood of serious disease, hospitalisation.
So you could also call them treatments rather than vaccines.
Maybe
we've changed the definitions, but yes,
yes. Well, sort of maybe preemptive treatments, prophylactics, if you like, I suppose. But for the efficacy of these vaccines, which we knew really from the beginning were not particularly likely to achieve sterilising immunity, but were likely to be, or the trial showed likely to be highly effective at preventing serious disease and death. The strategy, as it started, both in the US and the UK, and I believe in Europe, but and stated boldly by Matt Hancock and others in the kind of 15 million jabs to freedom, was that the vaccines would be used on the elderly and clinically vulnerable. And I believe for this particular disease and this particular type of vaccine that we have now, that is the only justifiable strategy, because there is a clear advantage. If you're in a class of people who, whether through existing medical conditions or because of your age, it is likely that if you were to catch COVID, if you were to catch if you're vulnerable, let's call it COVID. You could end up in hospital or die. There's a very clear case that the vaccines, you should have the vaccines, and those people should be focused on. With the original vaccine, second dose if need be. If the booster is effective, yes, they should have that, and as quickly as possible move on to vaccines that hopefully are more effective against variants, which I'm sure a lot of research is going on. Well, I know a lot of research is going on, but I'm not sure it's been enough of a government focus. But I think the case for the healthy, non-vulnerable, younger classes to have the vaccine is very, very questionable. It is marginal. It may be overall as a population, there could be statistically a benefit, but it is more likely that there is a benefit to a very tiny number of people in that younger, healthy population. And actually, for the vast majority of people, there is very little or marginal benefit, in the sense they would catch COVID, it would be mild, they will recover, and then they will have post-infection immunity. If they have the vaccine, they will get some side effects, they will probably be mild too, and they will have vaccine immunity. But given that the pros and cons are not that, that should always be left down to people's personal choice. I mean, I think it should be left down to people's personal choice for the vulnerable groups as well. Don't get me wrong. If somebody who's in a vulnerable group says, I don't want a vaccine, there's no way should law ever mandate they have to have it. I'm sorry, but I just don't agree with that principle. Unless it's somebody who's not capable of making their own decision.
What about care homes?
I think in a care home, if somebody is incapable of making
I'm talking about
decision,
staff.
I think that's a very difficult one indeed. I think that I'm very opposed to mandating vaccines in general.
There's 65,000 staff would
I think in
possibly
care
leave,
homes, it is probably the best case you could make that there is a case because the occupants of care homes are so obviously vulnerable.
But if they're vaccinated? Because the vaccine's to protect you, isn't it? It's not for anyone else.
The vaccine is to protect you. But I think this is where on net, I'm still against enforced vaccine. But if an operator of a care home decided that they were going to require their staff to be vaccinated in that particular environment, and probably that one only, I have sympathy.
But the same care home workers work also in the NHS with the same groups of vulnerable people, elderly, infirm, immunocompromised. So if you're saying that we move to hospitality again in a minute, but if you're saying that, there's some justification for care homes, then there has to be the same justification for NHS workers.
I think that in general, given that we know that the vaccines are not sterilising, and therefore that you can catch the disease and still be infectious, I cannot see any logic of not offering the alternative of regular testing. And I think that I am opposed to mandatory vaccination even for care homes home staff, but I think a system that said whether you're vaccinated or not, care home staff, there is a strong case for at least twice a week or every 2 days. Regular testing, and a negative lateral flow test, let alone a negative PCR, for me would offer more reassurance to patients in a care home than actually just the vaccination, which we know is not sterilising. So I'm not trying to say this makes me wishy-washy about whether vaccine should ever be mandatory. I'm just saying that care homes, we know that at care homes, 450,000 odd people are in care homes. Out of that small population, you got roughly a third of the whole deaths in the UK. So if ever there was a community that you knew and the government knew from day one was going to be vulnerable, it's that one. And therefore extraordinary measures for that one group of people, I think, is more justified than any other group of people in the whole of Western civilization. I mean, if you'd sorted care homes, it's
the problem. And hospitals, hospital acquired infections. There was up to half of people that went to hospitals got COVID in hospitals, in some hospitals, not all of them. And if you're already in with heart problem or cancer, well, don't fancy your chances, be lucky. So, hospitals and care homes were, as you say, a good place to focus. So you work in hospitality, and yet we now have this threat of Plan B hanging over us, where people would have to show a vaccine passport to go into Pizza Express or whatever. Would you feel very strongly that shouldn't happen?
Yes, I feel very strongly indeed. I think it is coercion. It is legislation by the back door. It is enforcement of forcing people to have a medical procedure by proxy. So
you call it a procedure. I mean, people just see it as a vaccine, or it's just like taking an asprin, or it's going to stop me getting COVID. But you actually call it a procedure.
Well, let me ask you a question. Would I be any less opposed if everybody was forced to take aspirin every day? Yes, I know. I would be just as opposed.
Yeah. Okay.
I think and if you take aspirin as an example, an incredibly safe drug, but now that you have the long-term data from the trials of aspirin being taken as a kind of preemptive blood thinner for people with potential heart conditions, they actually know after kind of years of data that more people, in fact, die and have complications as a result of damage to the stomach lining than lives were saved by the blood thinning, because we have very long 2, 3, 4, 5 year data. So that would not be the reason I would oppose mandatory aspirin taking, but I would still oppose it because I don't think people should be forced to, eat something, drink something, have something to have. I don't, by law. Encouragement, yes. Education, yes. All the things that governments, can and should do to, in terms of looking after their population. Mandating it, no.
So morally you feel strongly about that, but what about economically? I mean, what did we see in Scotland where that happened? I mean, do you not think, I do hear scientists saying, well, I would feel safer, and I think lots of people would feel safer if they went to a venue where they knew everyone had been vaccinated, and it's a good idea. So do you think it would hit the industry?
The data from Scotland so far is that it has made absolutely zero difference to infections and has just crushed a lot of hospitality venues. So
was there a drop of 40% or something?
40 to 45% was the early data.
Was that for nightclubs, wasn't it?
And yes, in nightclubs, an extra cost on each venue, an average cost. I mean, average is misleading, £600 a week. Which is a lot, by the way, to those who don't think £600 a week is a lot to a nightclub. That can be the difference between profit and loss of itself. 45% loss of business plus £600 a week cost will send most people from making a living to losing money and having to close. And zero evidence from anywhere in Scotland that it achieved any reduction in infections whatsoever. So, complete waste of time, morally wrong, economically damaging, and hundreds of businesses put out of business.
Do you think people decided not to go? I suppose you don't really know, but why do you think?
Of course, the idea these scientists have, in their kind of ivory towers and kind of well-paid jobs, and probably not that many of them nightclub goers or nightclub made, that there are people who would not go to a nightclub unless there were vaccine passes. I mean, it is so ridiculous to anybody who lives in the real world as to be unfathomable how somebody could think it. You're just saying, you must have come down from a different planet. Far, far more people will not go to a nightclub if they're asked for a vaccine passport, either on principle or because they haven't had it, than will not go because they're worried. I mean, do these people ever visit a nightclub? I mean, nobody should be allowed to opine on whether people want to go to nightclubs unless they themselves are users. They get very cross when anybody who's they don't consider to be an expert in their field makes opinions, and yet they're happy to pronounce on hospitality matters and nightclubs, which they probably haven't been in their lives, or certainly not for 20 or 30 years. It's just outrageous.
Do you think there's a case? I mean, do you think there was discrimination at picking on nightclubs and that younger group? I mean, why did they pick that as opposed to anything else, like a theatre, sitting next to someone?
I think there's a big degree of whether intentional or unintentional bias of the sort of people making the rules are not the sort of people that go to nightclubs, but they do go to theatre. That's without a shadow of a doubt. I think it's particularly unfair when the average age of nightclub goers is early 20s, who as a group contribute nothing to of statistical significance to either hospitalisations or deaths. Certainly the healthy ones who are out and about in nightclubs. Obviously, if you've already got a serious condition, you are, even in your 20s, you are vulnerable to COVID, but you're not likely to be, boogieing till 4 a.m. in that case, are you? So,
nor would you have been before COVID.
Nor would you have been before COVID.
Other respiratory diseases,
Apart from the fact they've, I suspect, picked on venues that the lawmakers, rarely go to. Except, of course, I guess, you have to... Notable exception to Mr. Gove for his exploits. Sorry, that vision was all. But apart from that, I mean, I think the idea of picking on a group that are the least vulnerable to severe disease is just bonkers.
It's difficult to understand.
Yeah.
I mean, do you think a lot of the regulations have been for people that don't understand about how poorer people live? The rule of 6, there's sort of 6 people that can sit round a restaurant table, and only seeing one other person. I think, if you've got 5 kids and you need to share your childcare, you wouldn't be able to abide by that. Do you think a lot of this has been a disconnect between what's going on in the real world? A lot of the rules have been
I think that's one of the big problems. I think one of the very big problems is yes, the rules have been made by people who have very different jobs and lives from those that are most affected by it, and therefore, if you're a scientist, if you're a civil servant, if you're in government, you have a very different type of life than the average person that will be going, out to the pub or a nightclub on a Thursday or Friday
or trying to survive,
or trying to survive. I think the bigger issue, and the issue which is a particular feature of this disease. Well, no, it's a feature of a lot of diseases, but I think the biggest single thing, though, in the kind of complete idiocy of the response and the public understanding of that response is that because you're talking about very large numbers and trying to deduce from very large amounts of data down to something that you can imagine in the real world, very, very few people, including those who should and do know better, on stage and in government, really appreciate the scale of the different risks for the different sections of society. So if it was a normal flu epidemic, or if it was 2018 flu, you would say, yes, of course, old people are still the most vulnerable. But there was, the data genuinely suggests that people, 18, 19 and in their 20s were at considerable risk, whether they were weakened because so many of them had poor diets and were coming back from the war or whatever, who knows. But there was a genuine risk across all age groups of the so-called Spanish flu, although I don't think it actually originated in Spain. But there was a genuine risk, and it was highest for the over 80s, but it was also quite severe. And therefore, a responses that targeted, whether it was vaccination, which didn't really exist at the time, but for flu, but vaccination or whatever across, might have been reasonable. This disease, you haven't got 10 times the risk if you're in a vulnerable group. You haven't got 100 times the risk. You haven't got 1,000 times the risk. You've got like 10,000 times the risk. So I think people really struggle to just quite understand that the vast majority of the community have really very little to worry about, or little even to do with this disease. It is a cough or a cough. I mean, I stopped following it actually, but the statistics that were coming out of the US university population when I last looked were that there had been, I think at the time I last looked, no deaths in the entire university population. So you could infect the entire university population of the UK with COVID. You could let them get, and you would quite probably not have a single death. Not one out of millions. Out of how many people are at a university? But it's a couple. You might have a couple of million people there. Everybody getting infected, and quite likely not a single death. If you had one care home with 100 residents, and you let COVID get in there, you could have more than 20. So from one care home with 100 people, just one building, and you let COVID get in, you could see 20 deaths versus 1 million students infected where you might get none or maybe one. And this differential scale is very difficult to explain in simple terms to people as to...
But isn't the idea that you can't cut a line through the middle of society, and that, those people in the care homes are going to be visited by, do you know what I mean? We mix, and you would know that more than anything. So you couldn't just, seal off a whole group of vulnerable people, could you?
No, I think this is a fundamental misunderstanding. The idea that it might possibly be easier to stop 67 million people transmitting a disease than protecting 450,000 people in care homes is just plainly ridiculous.
Well, not just care homes, though. You had people, an elderly person in a shop who's vulnerable. Do you know what I mean?
The data don't really suggest, strangely enough, that the kind of the elderly and vulnerable, which I expected to find when I looked at the data. I thought that the big...
And obesity and diabetes, there are other...
There are other conditions, but people with those conditions will mostly know who they are. But, when I looked at the data, I expected to find care homes be a massive source.
Yeah.
Hospital inpatients a massive source, both of which were true, and the second of which is clearly understated in the figures. And the only decent study is out of Scotland, which suggests maybe 40% of all those dying of COVID acquired it in hospital, or as a direct result of a hospital visit. And a similar exercise hasn't been done by public health England, not called Public Health England now, but but so, you know, there were the two big groups, and I expected a third big group of vulnerable and aged living at home. And funnily enough, they didn't particularly contribute. They're contributing to excess deaths, but not from COVID. And I suspect the reason is that those who are living at home, who are the most vulnerable, are not very sociable, and anybody visiting them will know they're a risk person, and therefore they haven't particularly contributed. So you're talking, you know, something like 2/3 of deaths originated in this very small. You know, there's only 140,000 hospital beds in the UK.
Hang on, 2/3 of deaths originated in
either hospital or care homes.
What is that? UK?
UK wide. I mean, that's what personally I think it's higher than that.
Yeah.
I think it's almost certainly, if we saw the true data, it'd be more like 75-80%.
So not in nightclubs.
Not in nightclubs. So you've got a population that in total might be 550,000 people, call it 450,000 people in care homes. You could, if you added some residential homes, you could get to a high number. 100,000 long-term hospital patients. Say there's only 140,000 total hospital beds in the UK. So you've got a population of 550,000. To suggest that it was not possible to protect those people, and not only not possible, but far, far easier than attempting to suppress spread in 67 million people, is possibly the most ludicrous assertion that has ever been made in a public health context. Because, and as evidenced by the fact they have failed to stop transmission amongst 67 million people. Whereas I know, and I'm not going to name names, I know a reasonably substantial care home group that in the first wave suffered, because they didn't know what to expect, suffered considerable number of deaths, let's call it 10% of their patient population. So a lot. And by the second wave, even before government measures came in, they had introduced regimes of testing, of kind of testing for staff, testing for patients, safe meetings with where people could meet, but there was, transmission was effectively prevented, and where in the second wave, virtually no deaths. And it's a big enough group for me, therefore, to know that if you had taken 100th of the total resources that were thrown at the COVID response and spent it on care homes, you could have reduced the total deaths in care homes from the kind of 50,000 odd that they are to, you might not have done it in time for the first wave, but to half that. Yeah. So straight away, you'd have had 20, 30,000 deaths avoided by that. There's no sign that any of the NPIs, the social distancing, have reduced deaths by that much. Vaccines possibly, but none of this other, and certainly nightclubs. There's also no evidence that the nightclubs and schools, were the cause,
the drivers
of the spread into care homes or hospitals.
No, there's none. No,
I mean, it's really difficult to explain this because it sounds so obvious that if people are spreading it around at school and spreading it around at home and spreading it around nightclubs and whatever, it will get into the hospitals, and therefore, if you can reduce it in the community, you will reduce it in hospitals. It sounds so obvious that for me to deny it sounds like I'm saying the earth is flat. But you have to understand the maths around this. This is not how people mingle. Unfortunately, that's not the. If you eradicated it completely from the community, then you might be okay. But if you don't eradicate it from the community completely, it's a step function of whether it gets into hospitals. You basically, once you have level X, your likelihood of going into hospitals goes up a step. And the reason is, in simple to explain terms, that the ill people end up in hospital. So the people that carry it into hospital are not actually the people who are going out in nightclubs and getting it and not being sick. It's when you get somebody who is sick, and it only takes that one person because the sick people end up in hospital. So it's not a case of saying if there's zero spread in the community, you get zero in the hospital. If there's 10% in the community, you get 10% in hospitals. If there's 20%, it's a question of, if you have zero, yes, you might keep it out of hospitals. If it's 0. But as soon as you start to get a bit of circulation in the community, some ill people will end up in the hospital, and then it takes off in the hospital and spreads in its own little network. So it's a kind of it's a little backwater of network theory that when you spread from a kind of low vulnerability population into a high vulnerability, you're effectively taking it from, in our number terms, R number 4, an R rate of 4 into an environment where R is 25.
Yeah.
So it goes in a step.
Yeah.
And so the kind of this idea, and this very, very compelling idea that you reduce the spread in the community will stop the issues in care homes, stop the issues, is in fact misplaced. Stop, yes. Zero, yes. But as soon as you've got any spread at all, you have to take different measures. And the obvious place is the nexus between the society, and the obvious place to sever the connection is at that small nexus between society and care homes, for example, not out in 67 million people. Protect those. And this example, as I say, it's a reasonably large care home company. Their success between first and second wave, which is absolutely factual.
But it wasn't that I know this is a bad phrase to you, but the more vulnerable people had already died. We'll never know.
There's a degree of that, probably.
The key is that, we can't lock all these people down to stuff. I suppose, do you think that the government sort of followed have followed a zero COVID policy by stealth, by trying to keep, called maximum suppression now, isn't it? By keeping infection dampening levels down. That seems to be a lot of what we've been doing, and actually it doesn't appear to have worked. Do you think that's the case?
I think that's exactly right. I think that's a very good point you're making, is that a failed zero suppression strategy is just a failed strategy.
More harm. More harm
and you either go for zero, which all of history
New Zealand
suggests.
Well, they've got their reckoning.
Exactly.
And they've admitted
all of history. But New Zealand, and again, you can't. New Zealand basically being like 3,000 kilometres away from any other sort of civilization, it's possible to do that. And
they've admitted they can't.
They can't control it now, but in the short term, you can, because they can take most of their freight is unmanned.
But in a way, this is looking at it sort of almost philosophically. The world took the hit. We all took the hit. We learned as we went along. It's almost like, New Zealand just didn't sort of, have any of the pain of that. They didn't experiment with these ideas, those ideas. They kind of sat like the elites in the, making up the rules. It's almost, we've all had to struggle and learn, haven't we, across the globe generally.